Welcome you to tonight's event on prescription medication safety and the Canberra script, brought to you by Capital Health Network, ACT Health, Carolina Drugs and Alcohol Service, and interested health practitioners in the Canberra region. First of all, Capital Health Network would like to acknowledge the traditional custodians of the land we are meeting on. We acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and pay our respects to their elders past and present. We also acknowledge and welcome any other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I am Dr. Leonie Harcourt, an Education Advisor at Capital Health Network, and also tonight's facilitator. Also with me is the Capital Health Network events team, the Canberra script team, and Anna McHenry, one of the directors from Carolina Drug and Alcohol Service, Dr. Paresh Dowda. Did I do that okay? Fellow GP and Canberra script super user, and ACT's Chief Pharmacist, Amanda Galbraith. So thank you all for coming. So Amanda, a little bit about each of our speakers. Amanda is the Chief Pharmacist and Senior Director of the Pharmaceutical Services section in the ACT Health. Amanda has worked as a community pharmacist for more than 25 years in the ACT and New South Wales, where she has contributed to patient care, both as a clinical pharmacist and the owner of several community pharmacies. And Amanda is also a credentialed diabetes educator and a board director for several pharmacy and health-related not-for-profit boards. Anna, who is joining us via Zoom, graduated from nursing over 30 years ago. Since then, she has spent 3 decades working in drug and alcohol field in a variety of clinical, management, executive and policy roles. Anna has her Master's in Health Administration and is one of the clinical directors at Carolina programs, where she plays a critical role in the clinical governance and leadership of the organisation. And lastly, Dr. Paresh Dowda has a portfolio of roles as a GP, academic, educator and consultant. And he's as a director and principal of an innovative outreach primary care service, as well as new technology-enabled practice, Next Practice Deacon. Paresh's passion for human-centred care and equity has been a central focus of all his work. His clinical practices focus on people with complex chronic care needs, and this incorporates aged care, disability care, and palliative care. So the format of tonight's event is that Amanda will speak first and we'll have Q&A after that. Then Anna will zoom in from Melbourne for her presentation. And lastly, we'll also have a panel discussion. So please think about any questions you would like the speakers to answer individually or as a panel. And for CPD, please report 2 hours of educational activities to your CPD home. We'll also be recording the event, so if you missed anything or you want to pass it on to your networks, we'll put it up on the Capital Health Network YouTube page in about 2 to 4 weeks. So over to Amanda. Thank you very much.
Cool. Good evening, everyone. Yuma, which is Ngunnawal for hello. I want to thank you all for coming tonight and for allowing us to talk to you about real-time prescription monitoring. And today I spent some time this morning with Shane Halloran, whom many of you might know. He tells me he's not an emerging elder, he's a prospective elder of the Ngunnawal people. And we were learning how to do acknowledgement of country in language. And he taught me a thing that I didn't know, which was if you go to an event and there are multiple speakers, that it's entirely appropriate for the MC to provide an acknowledgement. And if you were having a welcome to country by an elder, you would then have them do it. And then the next most senior presenter at an event should also provide acknowledgement. So if you don't mind, I will provide an acknowledgement in language for you and tell you a little bit about that afterwards. Tawura nuna, tawura nunawal, yangu nalaweri dunimunyan, nunawalwari tawurawari. Ningara Dindi, Wangarali Jinyan. So this is Ngunnawal country, and today we're all meeting together on Ngunnawal country, and we always respect the elders, female and male. I feel very privileged to learn from an elder how to provide acknowledgement, and it feels much more connected to me. So thank you all for allowing me to do that. So tonight we're going to cover a number of topics: opioid use and harms, real-time prescription monitoring, the information you can find in Canberra Script, what Canberra Script looks like from the inside, and any questions you have. I really like if we have questions as we go through. It's often much nicer to ask the question when the slide is there for me to answer to, and a bit more engaging as a presentation too. So do please ask as we go along. So a bit of a snapshot of opioid use for you all. So in Australia in 2016-17, 3.1 million people had one or more prescriptions dispensed for opioid, most commonly oxycodone. And about 40,000 people used heroin. It's higher than that now. And about 715,000 people used analgesics and opioids for illicit or non-medical purposes, which I find quite scary, really. That's a 7-year-old stat now, so just add a bit more to that. But what we're seeing is a disproportionate growth in harms. So you'll see on the chart here, so the largest circle is your opioids, and then the next largest is benzodiazepines, followed by stimulants, and then it ranges down from there. But what we're seeing is a 71% increase in the number of unintentional drug-induced deaths, but only a 33% increase in the population. And that's obviously of concern to all of us. So these are our opioid harms, and the drugs most commonly induced in the polysubstance deaths. So obviously the previous slide was just individuals, but this is combinations. So opioids at 81% and benzos at 66%. And then, of course, alcohol is the 25%, always a contributory agent. And you'll see in the unintentional drug-induced deaths that pharmaceutical opioids are those left two, so male in blue, female in yellow. So the middle on the bar chart is heroin, and the far right is methadone. But interesting to me to notice that the pharmaceutical opioids is higher in women and the other two in men. This is our calls for systemic change, and a real-time prescription monitoring offers some hope. The National Overdose Strategy from the Pennington Institute is seeking to assist in awareness and education of the concerns. And what we're seeing is the opioid stewardship issues, is the incidence of harms are now more common from prescribed opioids than from illicitly acquired opioids. And as a result of a coronial in late I think it was 17 or 18, Minister Stephen Smith committed to implementing Canberra Script as our ACT version of the real-time prescription monitoring. And any one of us could see patients with this same scenario, because I think often when we think about opioid stewardship or overdose from medications, we're possibly thinking about a population of the community that's very stigmatised. So the purpose for Canberra Script is to reduce harm and preventable deaths in the ACT community by supporting the safe and effective use of those monitored medicines. And to provide more effective care for consumers. When Canberra Script's not intended to say yes or no, you can prescribe, dispense or other. It's intended to give you a bit more information about your patients. So what can we see in Canberra Script? And I know a lot of you tonight have used Canberra Script and had a bit of a look around. Some of you might have looked at it a few years ago when it was first introduced and hated the little wheel of death that went around and around and around and around. I promise it's quicker now, so have another go. But it contains any prescribing and dispensing information for ACT patients, or for any patient when dispensed or prescribed in the ACT, or if a patient uses an ACT address when they are interstate. Now, we all know that cross-border data sharing would be the goal for all of us, and I promise you it is on the way. It's unfortunately not as simple as I always tell the tech people it should be. I feel like I should just be pushing a button and then we can see everything, but it doesn't quite work that way. But when we have cross-border data sharing, you'll be able to see all prescribing and dispensing across the country. But in the meantime, if you're ever concerned about a patient that you are informed is getting medications interstate, you can now apply for most jurisdictions' systems as well. Sometimes you can just put your suburb and then the jurisdiction, but say New South Wales, for example. And in ours, we have a little drop down that says that you're assisting patients in the ACT. So like a Queanbeyan prescriber can register for Canberra Script as well as SafeScript New South Wales. So one of the key things that we'd like to talk to you all about, sorry, I'm just going to go back now that I've turned the page. So what we're hoping with Canberra Script is that health practitioners can use this broader view of patient medication data to better identify patients who may be at risk of harm or dependency, especially from polydrug use. But I want to be really clear, it's not intended to disadvantage any patient who has a clinical need for medication. It's more a piece of evidence for you to decide how you're going to prescribe or dispense and to find concerning patterns that you might have. And really, it's a way for you all to feel more empowered when you're talking to your patients about medications. If I think about when I'm in the pharmacy myself and a patient says, oh no, I've never had X, Y, and Z, or I am taking other medication, but it's a little blue and white pill, and you're supposed to remember, having this access can help you with that. I do want to take this opportunity to also mention that we have a regulatory amendment sitting with the Population Health Minister at the moment, and that will expand some of the restrictions for prescribers on self-prescribing. So currently, prescribers are not allowed to prescribe opioids or other Schedule 8 medications and some benzodiazepines and the like. But now it's going to be all monitored medicines. And just as a matter of interest, the monitored medicines list, for those of you who don't know, includes all Schedule 8 medications, codeine, stimulants, pregabalin, gabapentin, and the Z drugs. So it's quite a broad collection. And that's codeine as Schedule 4 and Schedule 8. So those medications that I just mentioned to you now are all the ones that can no longer be self-prescribed in the ACT. That's essentially aligned with other jurisdictions. We just noticed that we had a gap, and so we're fixing that gap. So data quality, it's our key piece for you all, and we are really reliant upon prescribers and pharmacists to input accurate patient information. And recently there was a colleague of mine that I was standing in the pharmacy with, and they didn't have a patient's date of birth, which they needed for a Schedule 8 medication. So they put in the 1st of the 1st, 1900, which is the default date that pops up. And unfortunately, it was very difficult for us then to merge those patients together. So I'd encourage you to actually put the correct details in, not guess any incorrect details. And the note here about changes to date of birth requirements is that when this regulatory amendment goes through soon, it will be a requirement for prescribers to put patients' date of birth on all prescriptions. And just for the pharmacists in the room, that doesn't preclude you from dispensing if a doctor has forgotten or omitted, but we do require you to find the date of birth and put that in for the patient. But prescribing systems will be required to do so. And for those of you using prescribing software, we have been engaging with MSIA, which is the advocacy organisation for software providers, and they're all ready to go because it's already, New South Wales already has this in place. But if you find any data discrepancies, please contact the team at canberrascript@act.gov.au, and the team will merge any patients for you that you've got multiples in the system of, or where any changes are needing to be done. So accessing information in Canberra script. Patient consent is not required to view Canberra script information. So under our Medicines, Poisons and Therapeutic Goods Act, it's a requirement that data is inputted into any real-time prescription monitoring system and that clinicians can view that data. And any of that data, if any of them are concerned, is protected by both the Health Records Act and the Privacy Act and the Medicines, Poisons and Therapeutic Goods Act. So you can remind them that there's no concerns about that data and that we're very careful with that data. But here's the cautionary but. Canberra script does record who has viewed data in Canberra script and when they logged in, what they looked at and when they looked at it. And the reason we mention this is obviously to protect individuals in the community. So you're not able to look at the records of a patient for whom you are not actively involved in their care. We have had one scenario where a practitioner in the ACT was identified by another practitioner as having looked at their records. And this first practitioner was not involved in the care of the second practitioner. And so we did undertake some regulatory enforcement to restrict that first practitioner's work opportunities, really, I suppose. So please don't look at anybody else that you're not looking after their care. If you've never used Canberra script though, and you want to look at a patient so you can learn what it looks like, look at your own. I'm sure you can give yourself consent, but please don't look at family members or work colleagues. And these are the terms of use that you agree to when you register for Canberra script. It's part of our Medicines, Poisons and Therapeutic Goods Act, and it's lots of technical terminology, but basically it says you can look at any patient that you're involved in their care, but you must not disclose that information to anybody else, and that you are only able to do that when you're using a purpose prescribed by regulation, which is to say when you're looking after them in their clinical care. And it was discussed a couple of days ago with a colleague of mine who's a GP about how can we tell. And so what you can see on the screen here is, this is all fake data, by the way, that we're showing you. But you can see on these particular dates that a particular practitioner accessed a patient's records. And so we want to see you in there because that tells us that you are accessing it and looking at it. But we want to see you in there only when you're caring for patients in the ACT. And in a little while, I'll show you where you can access that within Canberra script. So how to get the most out of Canberra script. Kayla, I feel like we're missing a slide. Oh no, sorry, I apologise. It's up the top here. So see the green view access history up in the top right-hand corner? That's the little button that you can click on to get this slide to pop up. So in case you're not sure where that is, it shows you all of the access you've got for a patient. So Canberra script is available 24/7, and I mention that because for pharmacists in the room who are open till late at night, this is a really good way for you to assure yourself of sometimes the legitimacy of a script or information you're being told by a patient when you can't contact their regular GP. My team aren't available 24/7, I apologise for that, but you can definitely access it. And really what we're hoping for is that you check Canberra script for every patient when you prescribe a monitored medicine, and that you just make it a normal part of your workflow for controlled and monitored medicines. What we don't want is for patients to feel stigmatized because you're only looking at certain patients at certain moments in time. So I liken this instead to prescribing for blood pressure medication. Most GPs in the room, I'm sure, would only do that if they had checked the patient's blood pressure with their monitor in the room. And we all know that takes a few moments, and so does checking Canberra script. But you check the patient's blood pressure to make sure you can give them the most clinically appropriate information and make a good clinical decision. And looking at Canberra script is the same. So using it in that manner should reduce the assumption of any stigmatisation and support access to equitable care for regular and infrequent patients. And it helps you to understand some of the nuances of patients that you're treating, where you maybe are not sure of all of the practitioners in the treating team, or they may have been interstate, or seeking care for a number of different conditions from a number of different prescribers. And we want you to use it as a way to shape conversations on the safe and effective use of medicines. So inside Canberra Script, this is just the basic web page, so canberrascript.act.gov.au, and that is where you can register for Canberra Script. But you go to the circle on the left, which is the health practitioner login, and you can set up your access there. I'd just like to remind you all to use the email address that you have used with AHPRA, because that is how we make sure that you are a registered health professional, and the system in the background goes and talks to the AHPRA system and makes sure that you're registered on their systems. So sometimes if you're not able to log in, it's maybe because you're not using the same email address that you're using with AHPRA. And for those of you who are running low on their CPD for the year, there are also some CPD modules here. Still, thank you. Both for prescribers and for pharmacists. So there's a couple of combined ones and then some individual practitioner type ones. So a good opportunity to do that for you. And then after that, when you're registering and when you've registered already and you're just logging in, at the start of the day, you'll be asked to put in a 6-digit code, and that's what you can use for the rest of the day. So one of the doctors at the AMA that I was talking to recently, she was saying she gets to work in the morning, she logs into best practice, she logs into Proda, and she logs into Canberra Script, and they're just all her things for the day. And I reminded her about the 6-digit PIN for the day, and she said she loves that because Proda makes her log in how often? Anyone remember? All the time, right? Yeah. So we hope this is actually a little bit easier for you. So this is an image of a fake patient called Nancy Drew, for those of you who are old enough to remember her. Yeah, I can tell the old and young people in the room now. And what you'll see, this is a Fred dispense system. And on the top right-hand corner is the little icon. So you can click on this pop-up if you need to, and it will bring you directly into Canberra Script. Now, most software prescribing and dispensing has this pop-up notification piece. If yours are not popping up, it's either because your practice manager has kindly turned it off for you, or you may be using a software system that you need to talk to the software company to get them to connect it for you. But it's pretty common in most of the systems now. But it will bring you up not just that patient, but their profile on the bottom. Bottom patient is James Bond, and he's a really interesting patient. But because Anna from Karalika is going to talk to us about patients who may be using opioids, we're not going to focus on him tonight. We'll look at another patient for you. So this is our patient, Carla Espy. Carla is actually based on a real patient here in the ACT. With a real prescriber here in the ACT, but of course we've de-identified everything. So in the top right-hand corner, circled in red, is that view access history that I talked to you about earlier, where you can see who's looked at the patient. And you've got a number of fields here. The blue box on the left is your drug search. And that's useful because sometimes you can see a million things here, and you might just want to look at oxycodone, for example. So you can type oxycodone into that field and it'll just bring you up all the oxycodone prescribing and dispensing. You can also filter on whether it's a prescribing or a dispensing event, and you can pick a date range. So lots of opportunities there for you. And before I forget, I just would like to talk about alerts. So you'll see this patient has got a number of red alerts, and I just want to encourage you all not to use the term red flag. In 2024, red flags have a whole nother vocab in the social media world, on dating apps and the like. And if it's not in that space, then people will get quite nervous when they're told, and we hear this a lot, ACT Health has put a red flag on you. We don't want you to use that terminology, please. We're very happy for you to say, there's an alert that's popped up. I'm just going to go and have a look at that further. But to try and avoid those terms that might unknowingly cause a patient some concern or stress or anxiety, so that you know what they're all about. So, you can also filter and search within the profile. And so on this patient in particular, for example, we looked at, and the GP who did this patient looked at diazepam because they were receiving quite a bit of it and from a variety of prescribers. So what you're seeing on the right-hand side, the green, which I know is hard to read from where you are at the back, green is any of the dispensed events and blue is any of the prescribed. And one thing that we do notice, and I would really like to encourage the prescribers in the room who are not using software to please move away from handwriting of prescriptions for a variety of reasons. If you handwrite a prescription, the pharmacist can't read it, but also it doesn't come up in here. So then what you see is a whole bunch of dispensing events, just green, but no prescribing. And that can make it difficult for other prescribers and for pharmacists to work out what's being actually prescribed and whether they know everything that is being prescribed. As an aside, the Commonwealth are moving towards requiring electronic token prescribing for all controlled medicines and probably monitored medicines and maybe high cost medicines in the next sort of 12 to 18 months. Andrew, is that still timeline right? Yeah, cool. If you haven't been using software to prescribe, we'd really encourage you to do so. And if you need any help with that, there are a variety of software suppliers who can help you. But it does make the data more accurate and more useful. So we just want to have a little bit of a closer look at the alerts here for you. And Carla's alert is a red alert here. And what that's telling you is the patient has seen 3 or more prescribers in the last 90 days. And I just like to talk at this point about how that may be entirely clinically appropriate. So Carla, for example, may have presented at the hospital in an acute crisis. She may have a regular GP. If we think about a totally different patient to Carla who's not taking these things, Carla might have a pain specialist here in the ACT. She might travel to Sydney to see a specialist at Westmead or Royal North Shore, and that will bring her up arbitrarily with a red alert. But there's nothing wrong with any of that prescribing. That's totally appropriate. So that's where we say to you, please not to make a judgment about a red alert in your prescribing or dispensing software, but to come into Canberra Script and have a look at what it means and to dig into some of that detail. As it turns out with Carla in this scenario, Carla was visiting a number of prescribers to get benzodiazepines. And actually the GP in this case did a really good job of identifying that Carla was dependent on diazepam. And that is a clinical condition. It's not, saying no and see you later. So what ended up happening with this patient was the GP talked to all the other prescribers and talked to Carla and explained to her that she was going to set her up on the dose of diazepam she was currently taking. And over a very slow period of time, they weaned her down to a more tolerable, safe level. And they provided a benzo undertaking with the local pharmacy, and she collected her medications weekly. And ended up on a much lower dose than what this scenario is. And so that's a really good example of how real-time prescription monitoring can assist you to make good clinical outcomes for a patient. It stopped this poor woman having to go to a number of different prescribers and pharmacies to pick up medication too. So it took away some of that stigma she was experiencing. So here's Carla again. So as I was saying, this is just saying she's had 3 different prescribers or medical clinics within the last 60 days. And again, noting that a CHO approval can sit across a clinic for a number of prescribers to support each other Sometimes it could be 2 prescribers in that practice, but actually that doesn't cause any problems either. It might have been that one doctor was on holidays or the like. The other night I was visiting my pharmacy where I get my medications from, and we were talking about a patient that the pharmacist was concerned about, and they had a variety of medications. They had a large number of opioids and some medicinal cannabis and a stimulant. And I said to them, well, does the patient actually have a chair approval for all of these things? And they didn't know where to find that information, so I thought that we'd show you. So if you click on the second blue box from the right, it's currently saying medications because clicking on that would take you to that list of the patient's medications. When you're in the medications field, it says patient profile and brings you to this next slide we're on. So you can come in here to show approvals. And the one thing that's really frustrates me that, I'm sure somebody in the room could talk about and fix for me is this little icon is that green or blue to you all under the show approvals red box? It's hard to tell. But that has a short time period frame there. Please click on that and choose all time periods because sometimes you may miss a show approval because it's like 12 months old or longer. So if you just expand that to all date periods, you'll see everything. But then you can see here that this patient has a show approval. It'll tell you which GP or prescriber it's with, when it expires, what it's for. So that's useful to have a look. And if you notice a patient, if you're a prescriber or a pharmacist, is receiving controlled medications and they don't have a CHO approval, make an appropriate clinical decision with the person who's standing in front of you. Take some good record keeping in case your indemnity insurer ever wants to know why you went ahead. But do contact the team and we can always assist the prescribers involved to get their approvals so that you're not having to do that work. As long as you're comfortable with the clinical decision you're making, we can support you with the regulatory decisions. And here's one of our favourite Canberra Scripts case studies. This happened, and I know there's a lot of detail, so I'll fill in the gaps for you all, but this was one patient over about a 40-day period over Christmas and January between 22-23 summer period. So this patient ended up getting over 40 days, 230 oxycodone 5 and 448 capsules of pregabalin, which I think we'd all agree is not clinically relevant. It's actually worse than this because this patient we discovered was also seeking prescribing and dispensing from telehealth doctors in other jurisdictions and having them dispensed in pharmacies in other jurisdictions and then having them posted. So this is like a small version of the actual reality of this person. But the really interesting thing to see is that if you have a look at it, only 3 bottom left-hand side, bottom right-hand side, only 3 of the 26 prescribers who came and looked at Canberra Script, let me rephrase that, 26 prescribers looked at this patient and only 3 of them went on to prescribe. So most of them looked at it and said, oh, no, not doing this. Of the 12 prescribers who checked it, most of them chose not to prescribe the oxycodone for this patient. We were able to kind of rein this person in quite heavily. It did require a lot of work between other jurisdictions as well because this person used 4 or 5 versions of their name and their mother's name and a number of different dates of birth and a variety of different things. But it's a really good example of how you can all support each other by having a look at a patient like this. And even just going back to that access history piece, it's clinically really useful to know when you've got somebody in front of you that 3 other pharmacists today looked at this person or 5 other GPs today looked at this person. That alone gives you a bit of an indicator that the patient is perhaps looking for medications that they shouldn't be. And again, this sort of patient, please contact my team and we will assist the prescribers involved to put something clinically appropriate in place and or let other people know that they're misusing these meds. Some of you might remember this one. We actually sent out a named alert for this patient to discourage any dispensing, because they were often turning up at the pharmacy at 7, 8 o'clock at night, when it's really hard for pharmacists to know what's legitimate and what's not. So for those of you who haven't already, this is how you register for Canberra Script. Now, if you pick up your phone, you're not already registered, you can do this now while we're waiting. And if not, there are QR codes in the packs on the table in front of you, but you can register here on your own. You do need your prescriber number if you're a prescriber, so not just your APRA registration, but your prescriber number and the email that you registered with APRA. It's quite quick. It takes much less than 10 minutes. We should change that. Much less than 10 minutes, but it's available for you to do. If you're having any problems with that, just let us know. We're always happy to assist. And if you get back to your work teams and they're not sure how to do it, give them the info in your pack. But again, happy for them to contact us. And my lovely team who are sitting over here on the left, so Michaela and Kasoon and Michael, are very happy to come to any practice, any GP, any pharmacy, any nurse practitioner or healthcare provider, and provide training for you all. So the physical nuts and bolts of what to look at. Lots of resources for you. So our webpage, as I mentioned, the e-learning that's there for you all. There are some help topics, and Capital Health Network plug. There's a Benefits of Canberra Script YouTube video, and there's the Community Health Pathways available as well. And down the bottom are all of our IT support numbers. So the technical IT support goes to the RTPM software provider, and the general support and training come to my team. I'm very happy for you to contact the team as your first priority. And if we need to contact the IT provider, we'll do that for you. But I hope you've all contacted the team at ACT Health before, and they've looked after you. They're very kind, generous people with their time. Did you get the photos there in the middle table? Good. So any questions? I have a million things that I can help you with if you need it, but I'm happy to take questions from the floor.
How often have you found that pharmacists contact prescribers if they've checked Canberra Script and they've got a concern?
I'd say a lot. I was talking to a few of you earlier about my love of collaborative healthcare, and different health professionals talking together and working together. And sometimes it's just a case of, they didn't know they had registered for Canberra Script, or if the pharmacist has looked and found other information that they weren't aware of. So I would hope that people would do that quite a lot. Yeah. Hi, Chris.
Hi, I was wondering how generous your definition of involved in patient care is. We've got 25 or 30 doctors in a practice, and for whatever reason, I won't say people get flagged, but there's an online script or a new patient or practice manager raises something, and I'll often have a quick dive into Canberra Script or My Health Record, Medicare All, and just sort of make some sort of call.
I don't have a problem with that. Yeah. I used to always say this to first year interns and first year pharmacists: if you can defend yourself in the coroner's court, go for it. If you're making a good clinical decision that you want to support that patient's care, or Chris, in your case, you've got lots of prescribers who work with you and you might want to have a look and then let them all know, totally appropriate.
This is probably a question for the entire room, but when I give someone Nixoid over the counter, I have great trouble putting it in correspondence because it needs a Word document. So I just put it in the dispense label once the patient is gone. So does everyone
you brought up naloxone? Thank you.
Appreciate that, or like
that they can't put it in there? Okay, so let's come back to naloxone, because that's one of the other things that's in the regulatory amendment that's going through. At the moment, in our Medicines, Poisons and Therapeutic Goods Act, our emergency medications that anybody can use at any time for anybody are salbutamol and adrenaline. But this regulatory amendment that's about to go through will mean that anybody in the community can provide naloxone to a patient in need. And again, any patient that you're providing opioids to should be going home with naloxone. Where's Emily? Here you are. We were talking earlier about, a little old lady who comes in and gets opioids and then heads home. So you should be going home with naloxone. If you've got a patient who's opioid naive and they're starting, they should be going home with naloxone. So I hope that we get to the point where everybody's getting it, and so you don't even feel the need to note it, because it should be broadly given. The Commonwealth are real advocates for take-home naloxone program. For those of you who don't know, in the prescribing space, anybody can go into a community pharmacy who's providing the naloxone takeaway program and receive definitely 2 nasal sprays. It's still 2 of the
Yeah, it's
pen?
2 nasal sprays. You can also get the injections if you want to, but patients
most
don't
people
like
don't.
that.
Yeah, except when Nixwood was unavailable. But it's free. They don't even have to pay for it. So please encourage your patients to have it, and not only any of your patients, but if you have got a family member or a parent of a young person that they think is using opioids illicitly, please just have it in your first aid kit. And if it expires and you throw it away, then great, you didn't need it.
Is
Hi,
there
Emily.
a list online of which pharmacies are participating in the take home naloxone project? Because last I checked the federal government site, they didn't list which pharmacies were participating.
No, they don't. The Commonwealth
up-
say it's about 50% of all pharmacies, but I am hoping it's more here in the ACT. Michaela, can you write that down and I'll get Luke to put it in my newsletter? Health Pathways too. Health Pathways? Where's Russ? Oh, there you are. Yes, everybody should be getting naloxone and using it. Key take home points, don't prime. It's just 1 dose, so just use it as it is. And always call 000 because a patient can appear to be recovering and then done opioid receptors do their thing and they go downhill again. So as soon as you've used it once, call 000 and keep going. Hello.
Hi, I just had a question about the privacy of Canberra Script.
Yeah.
We just have a cohort of people who aren't Australian citizens and get really nervous around the registration process with Canberra Script. But
Yeah.
from what I heard you say before, they get worried around their residency if they get flagged on Canberra Script or if they get registered on Canberra Script, that will be a problem for them.
No.
Yeah.
So actually, I'll go back to the slide that has got that. And for those of you who are legislation geeks, probably just me in the room, and if Luke Karen was here, team at the back, him too. Section 97 of the Act is all of the legislative regulatory aspects around Canberra Script. And there are defined purposes for accessing the data. None of them include giving that data to anybody else, as in Customs, Home Affairs. No.
For a hypothetical patient, I have identified on Canberra Script to have multiple prescribers. Would I be able to approach your team to talk to the other GPs or the prescribers, or can I do that myself because I would have all the data? Is it going to be a breach of confidentiality?
No. So if you have had a look in there and you can see there are multiple prescribers, and if you've got a relationship with that prescriber and they're in Canberra and you want to ring them, please do so. If you are unable to contact the prescriber, then please contact my team. And for those of you who do any online dispensing of online prescriptions, it's really hard sometimes to get onto prescribers who are doing telehealth for anything, but particularly medicinal cannabis. Louise is nodding her head. Prescribers are required to put contact details on a prescription under our Medicines, Poisons and Therapeutic Goods Act. And I'm not talking about GPs and specialists in the Canberra community. I'm usually talking about telehealth prescribers who might be in Queensland or Victoria. But if you can't contact them because the phone number doesn't go anywhere, yes, we will help you with that. But if it's somebody and another prescriber in Canberra, please do collaborative care with them and talk about who's going to dispense, who's going to prescribe what, who's going to hold the approval. If they've got the approval, then you need to send the patient back to them. They can relinquish it to you if they want to. My team can help. But yeah. I just wanted to comment that there's a couple of dentists in the room and some nurse practitioners too. And so if any of you have any different thoughts or need any help, please ask questions later or contact me at any point in time, because I know it's slightly different practice processes for you all. And I'm sure that we are up for time, aren't we? Yeah, good. Lovely. All right. We'll have a panel discussion later on, so plenty of time for more questions. But thank you all for listening and for asking all those questions. It's really great. Thank you.
Okay, everyone. I hope you're enjoying your mains. Now we've got our second speaker for tonight, Anna McHenry from the Carolina Drug and Alcohol Program. So over to you, Anna.
Thanks very much, Leonie. Thank you for that. I'd also like to start my presentation with an acknowledgement. I come to you from Bunurong country of the Kulin Nation, and I would like to pay respect to elders past, present, any emerging leaders, and to any Aboriginal and Torres Strait Islander people in the room there today. So I am going to have it's a fairly short presentation on what Carolina programs provide. We are a provider of specialist drug and alcohol treatment in both the ACT as well as New South Wales. We started in the ACT 45 years ago, and we started by a call from community wanting more drug and alcohol services in the ACT. And our original site, which is in Fadden, was actually a homestead that was owned by a local GP. And he had some substance use issues within his immediate family, and he bequeathed his homestead to ACT government to be used for the purpose of providing treatment for drug and alcohol. So that's where we started our first 10-bed residential rehab. And the name Carolina was actually the name that the local Aboriginal people gave his homestead, which means on top of a hill. So that's where Carolina comes from. And that's where we started. We've certainly grown in the last 45 years. But we are a non-government, not-for-profit organisation, and we are largely funded by ACT, New South Wales and Commonwealth governments. We now have 7 sites and about 80 staff of nurses, counsellors, case managers, and a variety of other staff. We do not have any medical staff as part of our programs. We rely on local GPs, local pharmacists, local nurse practitioners to support our clients and our programs with their medical and psychiatric needs. So our services, we now have 2 residential rehabilitation services. As I said, one of the first ones was in Fadden, and that is now our family residential rehab, where single or dual parents can attend with their children from newborn to 12 years old, and the parents participate in the residential rehab program whilst the children are at school or daycare. We also combine that with a parenting enhancement support and program, and we also do that in partnership with organisations such as Mary Mead Catholic Care, the Childhood Trauma Centre, those sorts of places. We have a 30-bed residence in Isabella Plains, and that is for single adults, and we also can accommodate some couples. So what that means between our 2 programs is we can accommodate for pregnant women. They come into our adult program as a pregnant woman, either as a single pregnant woman or as a couple. And then a few weeks before birth, they move over to the family program, and post-birth, they keep participating in the program as part of the family program. We also take people in on opiate replacement therapy. We're unable to take people in who are prescribed other Schedule 8s and anybody on any benzodiazepines, and that's simply because with a single nurse available Monday to Friday 9 to 5, we're unable to keep a DD adequately or be able to dispense drugs of dependence regularly. We have a fabulous relationship, long-term relationship with the local pharmacy. And so they're able to provide the dosings once a day, and we transport the clients who require the ORT dosings, or sometimes if it's a single dose for ADHD, we transport them to the pharmacy and they can receive their dose. We also have in the AMC, we have a 28-bed program for men, and that is, again, it's about a 20-week program that come out of general population and into a particular unit where it's staffed by our staff and by some AMC program staff, and they participate in the rehab program. They can do that either as a way of before they're exiting AMC, and that sometimes it's a precursor to go into other treatment in the community. And sometimes they attend if they have, if they receive a long sentence and they've got significant substance use, it can make their time in jail much easier with a bit of rehab and a bit of alcohol and drug support. We have a range of community-based programs, including in New South Wales. That is largely for children and young people, where we have counselling, nursing and day programs available for them. And in the ACT, we have a range of community-based programs as well that we operate from our Deakin site. One of the ones that I would like to draw your attention to is our non-residential withdrawal program. That is nurse-led. So the non-residential withdrawal program, we have, when we're fully staffed, we have 4 RNs that work across Canberra and the surrounding New South Wales region. They can see people as young as 12. They also work with the other local drug and alcohol services, particularly the residential rehabs. So some of those young people may actually be going into the Ted Knopf's residential rehab, but they might need a nurse and doctor supported withdrawal period in that first couple of weeks. And so we'll go to Ted Knopf's and support that. It is for people who have a predicted low to moderate withdrawal syndrome, because this is people that are going to go through a withdrawal in their home, sometimes whilst they're working, sometimes whilst they're looking after children. So we need to make sure that that is kept quite safe for everybody. We do also sometimes, before people go through a withdrawal process, we may do a reduction. Some people only want a reduction. They don't actually want to do a complete withdrawal, but they just want to get things a little bit more in check and a little bit more manageable. And sometimes we also support people to stabilise, and that's particularly relevant to ORTs, opiate replacement therapies, but also benzodiazepines. Sometimes before we enter any kind of withdrawal phase, we actually need to convert and stabilise, and then we do a very slow reduction until we get to the point if they want to step off. Sometimes that's not clinically indicated and they may remain on a lower dose, but we've actually got them down to more of a therapeutic dose where it's not interfering with their life and it's not bringing any harms. Anyone can refer to our programs. We've got a phone number, we've got an email. The nurses have mobile phones. The nurses are mobile, just like your other community nurses. They work with other medical and psychiatric comorbidities, but they need to be managed and treated by GPs. And also we work tightly with pharmacists and GPs. And we also provide secondary consultations and sometimes some education and in-services. So please don't be afraid to pick up the phone and even just make an inquiry. We ask that if it's a secondary consult, it's de-identified, but just run a scenario past the nurses and they can maybe help to support. We also work very tightly with the Canberra Health Services Alcohol and Drug Services. They have the addiction medicine specialists, and sometimes we need the specialists involved with the GPs, with us, and with the pharmacists. But the nurses are the one providing the care in home and also the monitoring. And quite often, sometimes it's indicated that we need to step somebody up into the residential withdrawal unit initially to either do a reduction, stabilisation and or withdrawal, and then they're ready to come out into community care, and we'll support them before they go into the residential unit, but also as they're stepping out of the residential withdrawal unit as well. Some interesting facts from our team and our stats. So we pretty much are split down the line of people reporting their primary drug of concern as methamphetamines and alcohol. More than half our clients have reported polysubstance use. So that's where sometimes we're doing a withdrawal, a reduction and a stabilisation, maybe all at once with different substances. We do work to the New South Wales Health and the Turning Point clinical guidelines. They are very much our go-to for non-residential withdrawal. The New South Wales ones were updated and printed last year. So they're the most recent ones in Australia. We work with any substance as long as it's safe to do the reduction or the stabilisation or the withdrawal at home. We work closely, as I said, with the residential units, but we also sometimes work with the mental health step-up, step-down units when people are there and they need some substance withdrawal, stabilisation or reduction support. And unfortunately, we only get about 3% of our referrals are from GPs. So that's why we really love it when we're invited to forums such as this, because we have free nursing care that can support you, can support people at home and support the pharmacists around people's substance use issues. So just a very quick case study, just to give you a little bit of an idea how the team works. 51-year-old female was referred by the Canberra Health Service. On assessment in the hospital, it was clear that the client was still experiencing significant withdrawal symptoms, and thiamine hadn't been introduced as yet. The diazepam regime for the withdrawal was a little bit hit and miss. So we requested and we worked with the treating team just to get a little bit more of an extension of time where her withdrawal symptoms could be better managed at home, but where also the diazepam then was on a regular dose and we could then start doing a sliding scale reduction at home. There was also a little bit of head injury there too that we just wanted a little bit longer for some monitoring before we had her at home. She reported her alcohol use commenced to be daily in her late 20s following the birth of her 2 children. She reported about 15 standard drinks a day. We were unsure how accurate that was, but we go with what they say, and we also go with their withdrawal symptoms and their clinical presentations. And she was also smoking quite regularly as well. She was working full-time, but her relationship and her job were at threat. So she had adult children then, so the children and the children's safety wasn't an issue. And she was actually happy to engage in the program. We think the falls and the head knocks and going to hospital, she was highly embarrassed. There was a whole lot of shame. And so she was happy to engage to get home and to actually get some treatment. Yes, as we said, she was commenced on thiamine and we continued that for a little while. We also did an alcohol withdrawal scale and did the sliding reduction of the diazepam while she was at home. As a course of it, we also perform blood alcohol tests as well. We have their court-approved breathalyzers, as well as urine drug screens. And we have a 12 drug tester available. So we actually get quite a range of substances we're able to test as part of the urine drug screens. The nurse also, so after, about a week at home, the nurse supported the client at the GP referral because at that point, the most urgent thing for her was her cravings, her very strong cravings to drink. So we encouraged some naltrexone, some melatonin because she still had sleep disturbance, and to continue the Thiamine. GP spoke about introducing an antidepressant, which was great because there was definitely some mood issues, whether that was long-term or short-term, hard to tell. And the nurse supported NRT, so we also were able to manage her tobacco withdrawal from nicotine as well. She actually did very well. This client, she ended up ceasing the Thiamine because her diet improved and she was remaining abstinent. She ceased the melatonin. Her sleep disturbance was, well in check, and the naltrexone was working with the cravings. She maintained her job. She maintained her relationship, and she was still engaging in counselling and smart groups. So we were then also looking at discharging her from our services. So that's it for the presentation. Happy to take some questions. I can't see anybody. I can only see the lectern. But if people want to hand the microphone around and just let me know that they want to ask a question, that would be great.
So 3% of referrals come from GPs. Where do the rest come from? Is it mainly self or is it nurse practitioners?
Yeah, good question. It is about 40% self. Sometimes it's friends and family that also refer, and sometimes it's friends, family, self. Sometimes it's through CYPS, sometimes through corrections. Range of others.
Questions? Yeah. Can you jump in there? Thank you.
Everyone's just got their postprandial pause and just letting all their food digest. They're all looking very comfortable. So we might actually move on to the panel discussion. So if we could have our panel members, Anna's here, and Amanda and Paresh, if you want to come up. So if we don't mind, we'll just all stand here so we're near this microphone. Has anybody got any burning questions for the panel? Otherwise, I'll start off as some prompters and then if you have some questions, chip in as well. So this one's for Paresh because he hasn't been in the hot seat tonight. And he's a Canberra script super user. So I know that a lot of kind of GPs mutter that it's hard to use because it's not integrated into our practice software. So compared to a HealthLink CHO approval, which are automatically integrated into the practice software correspondence out tab, how easy is it to document a CHA approval applications through Canberra script in your practice software?
Great, thank you. I'm not quite sure what the definition of a super user is. It's all relative, right? So you can quantify what a super user actually means, but we the clinical system we use doesn't have the integration with SmartLinks. As said earlier, I do a lot of chronic people with complex and chronic care needs, a lot of palliative care. So the process around seeking an approval is pretty straightforward. Log into the portal. So I have we use a cloud-based system. I've got lots of favorites set up on Chrome. Every time I open Chrome, all the tabs open up, and it takes me about 8 minutes to log into all the different software in the morning. But once I'm in for the day. And then literally it's going in, finding the patient, selecting the category, and submitting. It's taken a lot of the hassle out from faxing, which is what we used to do a lot of before.
So thrilled to hear that.
The response comes back on the system, and you can click a link and it creates a PDF. So we just upload that PDF into our clinical system. We've also set up our clinical system so we can put in a reminder for 11.5 months or whatever time is appropriate to reapply for the approval. The reapplication process is even simpler because you go in, you click, you submit, and it's gone. Literally takes 30 seconds. I guess for me, because I do a lot of aged care, a lot of palliative care, I'm frequently logging into the system. So I'll do it in batches. So, once a week or so, I'll log in, spend 15, 20 minutes, go through all the notifications I've had around the CHO approvals that are going to expire, and resubmit approvals for them if they're appropriate. So, for example, yesterday I had 9 reminders. 5 of them had actually passed away because I did a lot of palliative care, but 4 I could just process. Took 10 minutes.
Could I just, so when you're applying for CHO approval, sometimes you have to attach a letter from the specialist, which will be in the software. How do you get the letter from the specialist in the correspondence onto the Canberra script?
So pretty straightforward for us. It's a matter of printing the letter. When I say print, we don't actually print to a paper copy. We print to PDF. And then in Canberra scripts, there's a correspondence tab at the bottom. So we just upload it into that and submit. So really, really straightforward.
I'll just add to that. You're right about the reapplying for CHO approval now. It is literally one click, just renew. So that's a really fast way that a lot of people don't know about because we only had that for a couple of months. Like that. And the other one you talked about, do you practice remotely or always from your practice?
So quite a lot remotely because I move around nursing homes and things. So just being able to log on using a cloud-based solution is really helpful.
Yeah, thank you.
So here's one, Dorothy Dixer. So why would people not use Canberra script?
You want me to take that or do you want to take that?
I'm happy to have it. I'm happy to have a go, but why don't you chip in? Look, I think it comes down to, a few things. For me, there's 3 main reasons I use it. One is efficiency of process. It's easier to apply for a CHO approval. It's a no-brainer. Even easier to reapply for one. The second thing is getting that history. So again, for me, I will have a number of patients where I've issued 1 month's prescription and 2 repeats. They don't request the repeats themselves as patients. Often the pharmacy will, another carer may. The ability to actually log on and see how many of the repeats I've issued have been dispensed is actually super useful in my context. The third is, that nervousness you get when you're prescribing an opioid, particularly if it's a patient you don't know, particularly if it's a colleague's patient. Maybe it's they're coming from a different practice as a new patient. And you get told a story. You're never quite sure whether that story is accurate or not. So a bit like checking your blood pressure. Actually logging into Canberra scripts and being able to see that history gives you a sense of confidence. It's collateral information, whether the story you're hearing is accurate or whether it's a little bit spun. So it kind of gives you that confidence around whether you're going to prescribe or not. The other thing I guess I find is where it doesn't quite make sense, actually spinning the screen around and having a conversation and a dialogue around it deepens the conversation. So I've kind of not answered your question because your question was a negative one, right? Why wouldn't you use it?
This is
I've
what makes
given you
me
lots of
use it.
reasons I use it. So, you know, I guess as a prescriber, I want that confidence. I'm never going to be 100%, but I want a bit more certainty than I used to have. And it gives me that bit more certainty.
I think some of the answers that we hear is I've never used it, so it's a bit unusual and I don't know how to use it. So please just log in, have a look at yourself, talk to the team, they can show you through it, is the main one. The second one is there are a lot of practitioners out there who don't prescribe. That's okay too. So they might not want to look, but if they're providing advice about a patient, you may still want to have a look. The one I hear a lot is that it's not integrated to the software for prescribers. Elephant in the room, that piece of integration that we made was so beautiful because we had control over it and we could get it done with the software providers. Unfortunately, what happens now is we no longer have an arrangement with the software provider ourselves as the ACT government, and it's now between the Digital Health Agency and the software vendor. And so we can't always get them to do things that we need them to do. In other jurisdictions, nobody's ever had that software integration, and so nobody seems to care about it, which is why I say it's, you know, we made a rod for our own backs here because it was so handy and so interconnected that that's the main piece I get from prescribers is you have to integrate it with your prescribing software. And so it's really lovely to listen to Paresh talk about how he uses it without that integration. And I don't know about you, but my children see a pediatrician and she loves it because she's never had any different experience. She doesn't have a prescribing system that she's using in that manner. And she does all her prescribing dispensing on cloud-based products, tokens to my phone, child approval done. George.
Paresh, you log in, do you stay logged in the whole day?
You need to put in a 6-pin code, and when it times you out, and then when it times you out, you just put in the 6-pin code again. You don't need to put in email, password, 2-factor authentication after you've done it once in the morning. It's just the PIN code you use afterwards.
But what I'm saying is, I'm a bit worried that you stay logged in all the time, all day.
Oh, no, it will log you.
So So you log in the morning. So what I log in the morning, you go through the login procedure. It times you out. I don't know how quickly it times you out. Maybe the team will be able to say, but there's a timeout on it. It's pretty short. If you then go back into it, you have to put in a 6-digit PIN to get back into it.
So is your concern that you're worried about staying logged in, but you've left for the day? And so, yeah, it will essentially time out. Yeah. It's actually a really good point for the pharmacists in the room who maybe are sharing technology with others. That for the moment, that's okay, but it is necessarily showing who was accessing it. It may be in your name and it may not be you. So that's something for the pharmacist to have a think about as well. Not looking at anybody.
Related to that, can nurses or reception staff access Canberra Script?
Again, another beautiful piece that we used to have when we had control of the system was that in Canberra we had what we called access authorities, and it allowed nursing staff to have a look at a series of patients. And the example I often use is at Building 7, they might have had the nursing staff go and access the patient's files to see what they're on, so that when they're engaging with the patient and the prescriber, they have all that information. Unfortunately, the way the system works at the moment is that there's a limited number of registered healthcare professionals who can access RTPM in its broad forms. Pharmacists, GPs, specialists, nurse practitioners, dentists. But nurses who are not nurse practitioners cannot access it. So it is a bit of a sadness to those of us in the Canberra team that we can't do that now. But moving forward, we anticipate a broadening of scope of practice for physiotherapists and all sorts of other professionals. And so the Digital Health Agency may have to look at that. I think it's simple for them to stay with registered healthcare practitioners, because then you've got some way to say, hey, you're not doing the right thing and this might cost you your registration. So I don't think it'll ever get to reception staff, but I'm always optimistic.
Any other questions?
And I know it's not the capacity to be able to sort of talk more about how to deal with the patients that, you know, might have a red alert, but you did mention about turning the computer terminal around to actually sort of, you know, use that as part of a deep dive into the conversation. Can you maybe just elaborate a little bit further about how that's received and how those sorts of comments and discussions continue?
So it's usually along the lines of, you know, thanks for sharing that information with me. Are you aware of something called Canberra scripts where all your prescriptions get logged? I'm just trying to reconcile what you said to me with what Canberra scripts says. Can we have a look at it together? And then really picking up. I start with picking up on the things that do reconcile, because, you know, it's always good to start with a positive, but then move into the bits where it doesn't quite reconcile and just try and get clarification around that. The scenario kind of goes in three ways. One is you know, the clearly issues, they've fabricated a story, it rapidly deteriorates and they'll leave. That's not happened, actually. Certainly not to me. I think it has to one of my colleagues. Often it becomes a dialogue where you start a bit of a negotiation around safe prescribing. So conversation then goes, look, I want to be able to help you. I want to be able to prescribe for you, but I have a duty of care to do that safely for you. I've got information here which is making me a bit concerned. So how can we move forwards around this? And so it actually just helps you nudge into a slightly different frame with the patient. Sometimes you do get the errors on there. You know, if it's been a handwritten prescription, it's not kind of made it on there. You know, sometimes you get errors around dispensing in terms of who the prescriber was on the dispensing history. So, you know, there are human errors that kind of feed into that. They're few and far between. I've invariably found it's helped build the conversation into a dialogue, which has been a constructive, healthy one.
Yeah, I can think of a scenario that happened on Friday, actually, where a GP contacted my team about a patient on stimulants, and the patient was definitely using more than was on the directions. And the prescriber unfortunately reprinted the Schedule 8 prescription and told them to take it to the pharmacy and ask them to show them when they'd been dispensed. Of course, that leads to a whole bunch of issues with a person having a previously dispensed Schedule 8 prescription out in the ether. But he did take it to his pharmacy and asked them to show them. And they rang me, well, not me, but the team, and said, what am I supposed to do with this script? And my team rang the GP, and the GP said, please tell the pharmacist to cancel that prescription, because I didn't want them to use it. I just wanted them to go and show it to the pharmacist. And so then the pharmacist wrote on the script that it was cancelled, and the patient went home and carried on to his lovely wife for a while. And then my team today spent more time. Now, if the GP had just done what you had said, logged in together and shown that individual, here's what I can see. Here's where I can see you have these 4 or 5 repeats dispensed. Let's talk about what's really going on and let's find a solution. There might have been less time for everybody involved. GP's probably spent 45 minutes an hour talking to the team over a couple of days. Patients distressed. Pharmacist has had time to waste. And it would have all been visible in Canberra script.
So how can the pharmaceutical services team help clinicians if the original prescriber's unavailable? So if they
Sorry, can I just add to the previous thing? I didn't mean to come out of nowhere, but if you find that someone is taking more oxycodone 5 than prescribed, it might just be a sign of undertreated pain. So they might need a preventative, they might need Lyrica, they might need gabapentin, blah, blah, blah. So I really would just talk to them if they're having use problems.
Yeah, I mean, the scenario I was talking about is with stimulants, but in fact, this is what was happening. The specialist had said verbally, I want you to go up to this dose, but the GP hadn't changed the scripts. So it was what the prescriber had wanted, but the communication just wasn't happening. So yeah, same thing with oxycodone and things. It's often just a lack of communication, or like with the benzo patient earlier, actually needed to be given a higher volume of them. And then like Anna was talking about, Karolika brought down again over time. Yeah. I missed the second.
That was the question about if the original prescriber is unavailable, what can the pharmaceutical services take?
Yes. So my team are really there to help you. And what we've seen in Canberra recently is when patients can't get onto their specialist prescriber or they don't have any of their specialists may not have sent a support letter to the GP or any of a number of different scenarios. And my team are always there to help you all with that. You know, often what we saw was through COVID when everybody was doing online telehealth in 2021 with a specialist that they can no longer find. It's now 2024 and they've gone back for review and they don't know where they are. So the team will always help you to make sure that the patient has continuity of their healthcare. We don't want people to end up with nothing. So just let us know if you need anything at any point in time. But please check camera script before you ring in case that would have helped you with all the thing that would help you with. And obviously you can see the CHO approvals on there. Now you know how to do that. But we're there to help you as needed.
Any other questions? So my last question for the night is, what's else on the radar for Canberra clinicians?
Oh, so many things, some of which we've talked about today. So we would like to let everybody know that we are having some big issues across the country with medicinal cannabis prescribing. A lot of it is telehealth again, where clinicians are not accessible. We do intend to start doing a little bit more work around contacting prescribers and pharmacies about only providing clinically appropriate volumes. So just like you would if somebody came in for their blood pressure medication 3 days ago, you'd have a conversation. So if they're coming in for their Medcan product sooner than what's clinically appropriate, or if the prescriber has given them 8 different things to pick a box, we're looking into that. Additionally, the pharmacy boards and medical board and nurse and what's the board for you guys? Nurse and midwifery one. They're all looking at inappropriate prescribing of medicinal cannabis. Ketamine is another thing that is suddenly really big in Canberra. Most of those ketamine scripts don't have a CHO approval. Please refer the patient. We'll give the information to my team. We'll look into it. But don't forget it is a Schedule 8 product and does need approval if the patient is going to use it for more than 8 weeks. So
We just repeat.
I'll repeat.
It does appear to me to be an extraordinary thing for
It
people
does.
to be using in the community at all.
Yeah.
And you would think that it should only be used in hospital in anaesthetic or, you know, severe antidepressant use or something like that. I would find it almost amazing that people having scripts for ketamine.
You would find it amazing. You'd be scared if you came and had a look at my system. So yes, ketamine's indication is for use in anaesthetic purposes, generally in hospitals, but we are seeing all sorts of therapies with it now, in creams,
In what?
cream, in troches, in
Oh.
use within. So some prescribers who might be a TGA approved psychiatrist for treatment-resistant depression and the like, maybe using it in psychedelic-assisted psychotherapy. There's a variety of things, but yes, it's gone from being kind of not very frequently used to overused. And concerningly, most of that is without the relevant show approval that's needed. So we are looking into that. Yeah. Yeah, it's horrible. And it is, you're right. For those of you who didn't say it, Matthew Perry's passing was associated with ketamine and alcohol, I think. And he was using really large volumes of it that were being injected. So it's made it quite topical, but it's already, we are already noting it here in the ACT and other jurisdictions. What else is coming? Well, we hope real-time prescription monitoring will cross-border data share. The Commonwealth tells us that will probably happen the 25-26 financial year. Nod at me, shake your head. No, okay. So that will be great because it will give you all more data and more clarity around your patients. Anything I've missed? No? Okay, cool. I think that's about everything. It has been a real pleasure to be.
I was just going to say, is it worth pointing out is that there is some recording of interstate
Oh, yes.
dispensing of
Yeah.
prescriptions,
So
but
if
it's based on the location of the patient's address as the database delimiter.
Correct.
So
yeah. So we get ACT patients who have been prescribed or dispensed in another jurisdiction. And it's prescribed or dispensed. So yeah, we do get a bit. And sometimes that's tricky when people log into, if you're a practitioner who works across the border, if you log into SafeScript, New South Wales and Canberra Script, don't forget that you'll see some doubling up, because just like we will see if they've been to see a Queanbeyan GP in our system, you'll see them in that system too. So it may look like there's a lot if you looked at it all together, but a lot of them are probably like matching. Yeah.
Well, we'll wrap it up there. Thank you very much to all our three speakers for such a very informative and wonderful night. And I hope everyone learnt something and also has further questions for the teams. The team's keen to hear from you. So we'll just give everyone a round of applause and thank you all for coming.
Thank you for having me.